Following our case presentations on HAPE, Dr. Bartsch will start us off with the first case.
This is the first case. It's a 59-year-old, healthy, well-trained man who has been on Kilimanjaro, who has been on Aconcagua, and has been on the volcanoes of Ecuador and never has had a problem. And he wants to go to the Ojos del Salado, and the concept is for acclimatization. They want to go first to this peak, 5,600 meters, then the next 5,900, and then the Ojos del Salado to acclimatize. Now, they drive to about 4,000 meters, 4,200 by car, and then they climb. And on the first day that he starts to climb, and he has to turn around at 5,400 meters because he has dyspnea and loss of performance. So he turns around. They go down again to 3,000 meters, and 3 days later, they want to climb this next little bit higher peak, and at the same altitude, the same thing happens. And he goes down again, waits for the others to come. They go all the way down to sea level. And about 5 days later, they come up again. And he wants to take part in this ascent and has to turn around at 5,900 meters. Same symptoms. After that, at 5,400 meters, he waits for his group because he doesn't want to spoil their climb. But his only wish is go down. He doesn't feel well. And he has dyspnea and he has cough, and nights are terrible. So he waits, and then they go down. As when he's below 4,000 meters, everything is okay. Is this a typical case of HAPE?
The reason this is not a typical case of HAPE is that HAPE would resolve with descent and typically does not occur when going back up. For some reason, perhaps vascular remodeling that takes place within even 3 days. People who have HAPE and go down and improve, when they go back up, they don't get it again. Right. Secondly, HAPE either gets better or gets worse. Right. He would have died if that was HAPE, yeah. And he tried to continue on like for the second or third time there, or he would have gotten better. So this is not a typical case of HAPE.
Does anyone have an idea?
How old was he again?
59.
And no previous comorbidities? No cardiac issues?
Well, he was the week before he left. He had a flu-like illness. And, but he felt well when they left.
And he flew from Germany to Chile?
Right. He flew from Germany to Chile, Santiago. When he came down to Santiago, he got a dyspnea, a pain with deep inspiration in his thorax. And it took a full 2 weeks till he came to the hospital in Germany. Then he played tennis at home, and he had dyspnea and he couldn't play well. And he only came to the hospital after he couldn't climb the stairs anymore without dyspnea. And when he came to the hospital here, he had clinically the signs of pulmonary embolism. The blood gases, ECG, and pulmonary artery pressure was increased. And you see here in the ventilation defects here and here and here where you have a good perfusion. And when you look at his legs, you see the thrombus in his popliteal vein. So, clearly.
I want to make some points about this. One is that in the mountains of Colorado, this is not uncommon. And that there's too much of a tendency for doctors to think, oh, they're dyspneic at high altitude, it must be an altitude issue. So I had a case that was referred to me had seen 3 other doctors in high altitude in Colorado last month. This woman came in and she has a second home in Colorado. She'd been dyspneic for a couple of weeks. And she felt fine the first 3 days at altitude and then started feeling poorly. And none of the docs had picked up that history. So I did a CT angio and she had multiple pulmonary emboli. So just because somebody's breathless at altitude and they're in Colorado and maybe they've doesn't mean it's HAPE or it's an altitude illness, and too often we will miss. You have to think of the common things and not necessarily esoteric things.
The case was 1996, so there were no CT angios at that time. That's why.
Hackett's point about how good people feel after they resolve their pulmonary edema. There are so many of them here in Colorado that want to go back up skiing after they've been in the gotten treatment, whether it's pharmacologic or oxygen. And I remember Mike Yaron's studies that he did on the gamma bag back in the early 90s, and the patients who resolved stayed up in those resort towns and went skiing the next 2 to 3 days. So there is something that happens. It happens so quickly to get to the point, and then it happens so quickly to resolve it that it's just fascinating.
So there's two aspects. One is we pioneered keeping people at altitude to treat their pulmonary edema in the 80s. In Summit County, when we were doing our research there, we had an echo lab set up at Keystone in the parking lot in an RV. And before that time, the standard of care in Colorado was to send anybody with pulmonary edema down to Denver or to a low altitude. And I had this guy from Britain who was there on his honeymoon. He paid a fortune to come there. And he really didn't want to go down, and so we sent him home to his condo on an oxygen concentrator and checked him every day because we were pretty nervous about it. And he did great. He was able to consummate his marriage. He was very happy. And
Well, we don't know that.
Yeah. So and now it's evolved so that now most people with HAPE are treated on site in the mountains with oxygen, a duration of average of 40 to 60 hours. And after that, they can generally go ski if they want to stick around that long. And then they don't have to separate from their families. They don't have to get a special airfare back and all that sort of thing. It's quite convenient. Then the second is the people that you do send down, they get better more quickly. Instead of 4 days, 3 or 4 days on oxygen, they're better in 24 hours. But you can't let them come back up before 48 to 72 hours because it takes our clinical experience and our experience that we measured on Denali's, it takes about 72 hours of recovery at a lower altitude. And then when they come back up, they don't get it again. They're protected. So it's very interesting. I presume it's remodeling.
Does that also apply going back to sea level? You argue with remodeling. How low can you go till you don't have remodeling anymore?
Good question. I don't know.
And how long does it last then?
And how long?
Yeah. So how long are you remodeled for before you're HAPE susceptible again when you go back up?
Yeah, I don't know. On Denali, we'd send them down from 14,000 feet to 11 feet. They'd stay there for 3 days. Then they'd come back up the summit at 20,000 feet. Not a single one of our cases ever got HAPE again when they came back up that second time.
So we did some unpublished work. We reviewed 100 cases of HAPE, and then we called them to see if they'd ever come back to Colorado. These were tourists and 30 of them had, and none of them had HAPE again. And the reason we didn't publish it is because there were too many variables. Some of them took some medication, some of them stayed in Denver, some of them, but none of them ever had HAPE again. So it's a interesting. I don't know how long that memory lasts, but it also raises the issue that you have, which is 20 to 30% of your susceptibles in almost all of your studies don't get it at a particular study point again.
Yes.
And it's curious whether there's a pattern to that 20 to 30%, aside from the mechanistic issues, whether there's some demographic stuff about that 20 to 30%.
I think we also have, we don't have good data about confounders. When you have had HAPE once and you take part in a study, you might tell others that you did never go to altitude in the last 2 months. But I don't know. I could imagine that some of these guys did pre-acclimatization to some extent because they didn't want to get HAPE.
Next, Dr. Hackett will present a case on HAPE. Dr. Hackett is world-renowned high-altitude expert and altitude research pioneer. He's clinical professor of emergency medicine at the University of Colorado and also director of Institute of Altitude Medicine at Telluride. He's founder and director of Denali Medical Research, and he's past president of International Society for Mountain Medicine and past medical director of Himalayan Rescue Association. Let's begin with the case.
Case is actually courtesy of Marco Maggiorini, a colleague of ours from Switzerland. 30-year-old male, ski between 2,000 and 3,000 meters. That's 6,500 to 10,000 feet. Developed what was called an infection of the upper airways with a dry cough. 3 days later, at 2,500 meters, 8,000 feet, he developed a productive cough with yellow secretion and rapidly progressive dyspnea. The hut keeper happened to have a thermometer and measured his temperature of 39.2. He deteriorated rapidly, and he was flown out by helicopter from 8,000 feet, which is actually relatively high for the Alps, even though we don't consider that very high in Colorado. On exam at the clinic, he had rales and wheezing. His ECG was normal. Here's his laboratory findings. A white count of 15,200 without toxic sings. And his ABG showed significant hypoxemia with 80% oxygen. His saturation was only 72%. And his chest x-ray showed extensive infiltrates, perhaps right greater than left. And the differential, as is so often the case, is infection versus edema. Cardiogenic edema, non-cardiogenic edema. So he grew out Haemophilus parainfluenza in his sputum. His blood cultures were negative. He was treated with a vasodilator, nifedipine, antibiotics, and somebody threw in furosemide. It'd be surprising how many people with HAPE and other things get furosemide even in Colorado. And follow-up 72 hours later, much improved. His fever was gone. His saturation was 90% on room air at a lower altitude. He said he was discharged the next day. So, what did he have? And is he a HAPE susceptible person? And what would you advise him if he wants to go to the mountains in the future? Any ideas? Could he have had pneumonia? Certainly. He had a temperature of 39, an elevated white count, grew out Haemophilus parainfluenza. Could he have had...
I would suggest that if he had bilateral pneumonia with that significant amount of infiltrate, to get better in 3 days would be pretty unlikely.
People agree?
Yes. It's like he was heading for the vent with pneumonia.
So this is indeed so true clinically in Colorado. We see these people come in the clinic with horrible chest x-rays, and they're walking and talking, and their oxygen saturation is very low, but they don't look like they're about to die. You see somebody comes in the ER here with a chest x-ray like that from pneumonia, they look like they're going to die. And you're going to tube them and put them in the unit. So clinically, it's a big distinction. But could he have had an infection that triggered the HAPE? And is there any reason you can't have HAPE and pneumonia? No, of course you can. So there may have been an element of infection. And in the mountains here in Colorado, we often cover people with antibiotics. If it's not exactly clear, or if there may be an infection element, why not? So was it HAPE or pneumonia or both? So is he HAPE susceptible? That's the question. He wants to go back to the mountains. So he went to see the doctor in Zurich. They did a clinical examination, which was normal, and echo showed no ASD, which could be a contributory factor to the HAPE susceptibility, or other cardiac pathology. And then they said, you know, we're not sure what happened to you last time, but we're doing a HAPE study. Maybe you'd like to enroll in our HAPE study. So he said, sure. So in Zurich, they did blood gases on oxygen and on room air. And you see, on room air and with 12% oxygen breathing. And you see, with 12% oxygen breathing, he becomes markedly hypoxemic. Does not very well defend his oxygenation. I mean, most of us, 12% oxygen. Peter, in this room, if we all breathe 12% oxygen, wouldn't our saturations in PO2s be a little better than that?
Yeah, between 75 and 80.
Because we ventilate more.
Average,
yeah. Yeah, he really didn't change the PaCO2 very much, did he?
Not much.
He does not have good ventilatory response to hypoxia. You can tell by his CO2. So, since he was part of a HAPE study, he got to get a free pulmonary artery catheter. That's genius. And here are his measurements.
What a bonus.
So on 12% oxygen breathing, his heart rate goes up. His systolic pressures don't change very much, go up. But his pulmonary artery pressure significantly. Now this is not after 2 hours, because they don't keep the catheter in that long for these studies. This is just after like 10 or 15 minutes. So if he had been for 2 hours, as Peter suggested, to get a full response, it probably would have been even greater. And he has an estimated capillary pressure of 20, and a PVR went from 146 to 249. So this looks like maybe he's HAPE susceptible. How do we know for sure? We take him to 15,000 feet. And at 15,000 feet, he went up there in 2 days. During the ascent, he was slow, complained about weakness and dizziness. On arrival, he didn't look very good. He had mountain sickness with a score of 4, which is mild mountain sickness. However, 5 to 6 hours after he arrived, he deteriorated. He was vomiting. He had slight ataxia. You could hear rales. So this fellow was a very good subject. And his chest X-ray at 15,000 feet shows significant pulmonary edema. So now let's catheterize him. And now room air at 15,000 feet, he's got an arterial PO2 of 19.5, despite dropping his PCO2 to 24. So he's got some ventilatory response, but he's still incredibly hypoxemic with a very large AE difference. So when you give him oxygen, his saturation improves to 60%, his PO2 to 36, and he improves some in terms of his blood gases, but not. So I asked Marco, how can you keep a person PO2 of 36 as part of your study for a while you're doing studies? I said, well, that's just the way it is up there. Oh, you want to So, of course, they were watching for any deterioration, and they only gave him that for a short time. Then they put him on 100% oxygen. And if you look at his pulmonary artery catheter measurements, you see that on room air at 15,000 feet, he's very similar to what he was with 12% oxygen at low altitude. Almost identical, really. A higher mean pulmonary artery pressure. And his pulmonary vascular resistance, however, is higher. And on oxygen, this is very interesting. Peter maybe would comment on this. On 33% oxygen, which granted we might have seen more of a response with 100% oxygen, but his pulmonary pressure didn't change from room air to 33% oxygen. And his pulmonary vascular resistance calculated actually went up a little bit when he was put on 33% oxygen, despite an improvement in his oxygenation.
What was the time frame on that, Peter?
How
long was he on oxygen?
Well, he's on oxygen, 33% oxygen for about 15, 20 minutes before these measurements were done.
And this normalizes PO2 to low altitude. That's all. I mean, you have a lung problem, and you normalize PO2. So it's not 100% oxygen, and it's very short, so I think...
So what you're both getting at is that if you had given for a longer period of time, or if you had given a higher concentration, you probably would have seen more response, which
I'm sure he will have. He got it, because we don't try to kill people up there.
Yeah.
It was just a study. Said you got the data out of the cath study protocol. As soon as that was finished, he was on 100% oxygen.
But the response is generally, I mean, from a PA pressure standpoint, is quick. I mean, we do hypoxic challenges upstairs, trying to mimic altitude in some of our patients, and taking the 12% oxygen in the cath lab, and I mean, their PA pressures are up because it's like in minutes. We turn it off, they're down in less than minutes. So I do find it interesting why at 30% we're not seeing much more change in a PA mean that stayed essentially the same in PVR that went up.
Although his cardiac index was down substantially on the higher oxygen.
Because his heart rate had come down so much, I think.
Right. But if we're attributing again PVR or PA pressure or PVR probably more appropriately to leak, which I think then why if it's is it more than hypoxia? I guess is the point. Is there another altitude effect here that's going on?
Well, there are data suggesting there's more of a fixed obstruction after a while with this disease, that you can't reverse it immediately with oxygen.
And he has a rather high pressure. with 66, and he had probably has it for a long time. Something else that's very atypical is you usually don't get HAPE 6 hours after arrival into Margarita Hut. It comes at the earliest, at the very earliest, usually in the night towards the morning of the first night. So he might have,
So
might be-
he was treated with nifedipine and dexamethasone, and he improved rapidly. His ataxia disappeared, and his oxygen saturation was good. However, he was evacuated by helicopter, returned home, had a high-resolution CT of the lung. A month later, that was normal, and he did not volunteer for any further studies. So I think we discussed most of these points for discussion. We can go on to.
Would you think with the emesis and the ataxia that there's a cerebral edema component as well, or just AMS?
People with neurologic changes with HAPE, it's either cerebral hypoxia, which generally causes drowsiness and decreased level of consciousness without ataxia, or it's some cerebral edema, which causes the ataxia and the vomiting. He probably has some cerebral edema as well, which is why they gave him the dexamethasone.
You could do an MRI now with a susceptibility-weighted imaging and look for microhemorrhages. If this was really a significant cerebral edema, you'd see microhemorrhages.
So what Peter's saying is a little off HAPE, but for you clinicians down here, it's a really interesting point. If you have somebody who comes down from the mountains that you think had cerebral edema, that's not clear, you can do an MRI to look for these microhemorrhages, and you can even do it years after their cerebral edema, and they'll still be there. You see the little hemosiderin deposits. So just the last point is, if this guy did want to climb Kilimanjaro, you'd want to put him on a pulmonary vasodilator as prophylaxis, and perhaps acetazolamide as well. Diamox to speed the acclimatization, and then pulmonary vasodilator to keep the pulmonary pressure down. And he'd probably, perhaps he could climb Kilimanjaro, but you wouldn't recommend he go try it first. You'd recommend he go back to this place, which is safer, with good medical care on these medicines, see if it helps. And then if that worked, you might recommend you go to Kilimanjaro.
Next, Dr. Carpenter will present 2 pediatric HAPE cases. Dr. Carpenter is Associate Professor of Pediatrics and Pediatric Intensive Care at the University of Colorado Children's Hospital. He has performed extensive research in the field of altitude-related illness in children and the effects of viral infection and hypoxia on expression of angiogenic mediators and their contribution to development of pulmonary edema. So let's begin with our first pediatric case.
One of the things that's striking is the number of reentry cases that we see in Colorado. There was Dr. Bartsch mentioned early on sort of the 2 classic forms of HAPE being the low altitude first ascent and then the high altitude resident reascent. The latter form we actually see much more of, I think, in kids, at least in the ones who end up coming down from Summit County to our shop. I'm going to pick up on a couple of the themes that were touched on earlier, especially the infection versus HAPE that Dr. Hackett just mentioned. I'll go through this first case fairly quickly because I think it overlaps a lot with the one he just presented. This was a previously healthy 11-year-old girl with no personal or family history of altitude-related illness, resident of Breckenridge, so about 9,600 feet, went on vacation with her family to Florida for 3 days. While in Florida, she developed some URI symptoms, nothing major, but a little bit of a cough, sore throat, didn't feel great. Was very tired on her first day home, and over the next 24 hours was noted by her parents to have a fever of 39. That night, about 36 hours after returning to her home altitude, her breathing became much more labored. She was taken in to be evaluated in the Summit County Emergency Department, where she was tachypnic, quite desaturated on room air with a SAT of 69%. Other labs, generally unremarkable. White count a little bit elevated with a little bit of a left shift, but no bands. Maybe a little bit dehydrated from the BUN creatinine ratio. And she had this chest x-ray, which I think, again, fairly typical. Patchy alveolar infiltrates, right greater than left, certainly consistent with diffuse edema. And as Dr. Hackett mentioned, really worse than you might expect given the fact that she walked into the emergency department instead of coming in lights and sirens. There was concern there, again, this classic dilemma, how much of this is infection, how much of this is altitude. So she was started on cefuroxime and azithro and sent down to Denver. I mentioned the time here, so this was at about 3 a.m. that she presented. By the time she got her IV, her antibiotics, and arrived in the Children's Hospital ED in Denver 4 hours later, she was not in any distress. Her respiratory rate was 26. Her room air sat was in the mid-90s. And although she did have rales, she really looked fine. She was admitted as a pneumonia plus minus HAPE. Mild URI symptoms persisted, but she was off oxygen in 24 hours and sent home in 48 hours on some oral antibiotics. As best as I know at this point, she's not had any recurrences since, although I don't honestly know how many additional trips she's made to low altitude and back. And so I think, again, this really raises a couple of these issues that we've touched on. How do you tell how much is edema and how much is pneumonia? Is the altitude setting enough to safely defer antibiotics, or should all of these patients be treated for both? Since oftentimes, especially in kids, we don't end up with positive cultures if you're treating somebody with for pneumonia. And I think it also touches on the question of viral infections as a trigger. She did have URI symptoms that preceded her reascent and her illness. I think this is an association that has been noted in the past. The mechanism by which that happens is unclear. I have a personal pet hypothesis which has to do with venoconstriction and the fact that young animals tend to have a more reactive pulmonary venous bed than older animals do, and so is there potentially a role of a viral infection in exacerbating that sort of process? But I think, as Dr. Bartsch mentioned earlier, there's not a lot of evidence to support or refute that idea. I think, let me go on to the next case, because this one is actually a little bit more controversial and might generate a little bit of discussion. Yeah, please.
So will you ever not treat these kids with antibiotics? I mean, will you go out on that limb?
You know,
as a clinician, like that's what I want.
I have the easy out. I work in an intensive care unit, and if they're sick enough to end up in an ICU, I feel like they deserve antibiotics. I think it's a much trickier question when you have someone who has a bad X-ray but a good clinical presentation, and you're not entirely sure what to do with the admit, not admit antibiotics.
If I could comment on this case,
please.
She made such a dramatic recovery with coming down to Denver. I would not have admitted her to the hospital probably, and maybe sent her home on supplemental oxygen, but not even. Her saturation was 94% on room air. So she's cured. I mean, she's improved. She's not going to get worse. She's going to be fine. And but you had the advantage of seeing that change from high altitude to low altitude. I mean, I can't tell you how many times I've put unconscious persons in helicopters in the Himalayas or on Denali, and by the time we get to Kathmandu or in Anchorage, they wake up and they don't want to pay for the helicopter bill.
Well, when would you send
It's
her
dramatic.
back up? Dear, when would you send her back up then?
Well, she lives there, so I
Yeah.
would send her back up on Diamox.
Okay, so let her go back
A
up.
couple,
and-
a day later, 2 days later,
Okay.
3 days.
You
later.
would wait.
I would wait a couple days,
Just
because
like you said.
it takes a little while for her all that fluid to resolve.
So do you think you can see fever with just HAPE, or are you sticking with the second hit? It needs she had a virus and she got HAPE, or going back to this inflammation paradigm, is HAPE enough to give you a fever if there's any?
HAPE is enough to give you fever, but I wouldn't call her a reentry HAPE. I wouldn't label her as somebody that needs Diamox every time or needs to be carefully watched, because she probably had an infection that triggered it. If she had the URI symptoms, but the next time, if she developed it a second time, then we would label her as a reentry HAPE person, and we would prescribe Diamox for each time she comes back.
And that's
until a certain age, until she seems to grow out of it.
An interesting distinction. I'm in the middle of putting together a series of the last 10 years worth of reentry HAPE kids, as many as I can get my hands on from the children's and some of the county medical records. And if you go through and look at the reentry kids, this virus association is actually less prevalent than was reported 20 years ago in what was primarily a classic HAPE sort of first ascent population. And so a lot of the patients who get reentry HAPE with every trip to low altitude, and there are a number of families that have even had to move away from high altitude spots because every time they go on vacation their kids get sick. The viral symptom association is not as strong in that population so far as I can tell.
So Todd, when Scoggins first described it, I don't recall there ever being any description of preceding illness in those kids. Was that just an absent retrospective analysis, or do you think things have evolved since
If
then?
you go back and look in those earlier studies, there are several in that. I think that first series of 26 or so, there's not a lot of details, but there was Jim Wiggins' study shortly after that had 8, and I think of the 8 he describes 3 with URI symptoms in the fine print, but it wasn't picked up as a major theme in the article. So I think this is something that's out there, but it's a little bit hard to tell exactly how prevalent pathophysiology it is. Which leads into this case nicely.
One question. You give these real scent cases, you give acetylcholine. With which idea? Lowering pulmonary artery pressure or enhancing acclimatization?
Yes.
Wait a minute.
It does both. I mean,
Do you have data for the pulmonary artery pressure?
No.
No, did Buddha study that from when he studied that in Bartsch?
Well, that's not relevant, I don't think.
Well, he studied PA pressure with acetazolamide directly and didn't find a decrease.
In people who were partially acclimatized to 4,000 years. It's not the same. So, I mean, these parents, we wanted to do a controlled trial of Diamox versus placebo for bringing their kids back. The parents say, "Are you out of your mind?
I'm giving them Diamox.
We're not going to give our kid a placebo." This is a big deal for these families. And they love the Diamox. I get calls from Hawaii and Florida. "We forgot the Diamox. Did you call in a prescription? My daughter won't get on the airplane." So we're never going to have a placebo-controlled trial in HAPE susceptible kids. And in Buddha's study, those were not HAPE susceptible people, and it's really irrelevant. There are studies with acute hypoxia in humans showing that Diamox blunts hypoxic pulmonary pressure response. And there are studies in dogs and rabbits as well showing that you can block hypoxic pulmonary vasoconstriction with Diamox. So there is a plausible mechanism.
Dr. Carpenter will now present the second case on pediatric HAPE.
So this patient is one who actually did end up in my ICU. This is a 12-year-old boy. Again, no personal or family history of altitude illness. Lived at about 7,200 feet in the Colorado Springs area and went on a car trip to Houston for 7 days. I mentioned car trip just because it's a relatively slow reacclimatization on the way back up, which is a little bit different than the typical "I flew home and then got sick." He did not report any URI symptoms, although was quite tired on the first day. Had worsening cough through the next day, then some chest pain, and ended up in the emergency department that evening. His initial evaluation at a low-grade temperature was noted to be coughing up some pink frothy sputum. Room air sat was quite low. It did not really come up as well as people would have liked on a lot of supplemental oxygen. Laboratory results, again, not particularly impressive. A bit of a left shift. Had a chest x-ray that was read as diffuse nodular infiltrates, and the decision was made to intubate him for safety during transport on the way up to Children's. This was his chest film. So that was his initial x-ray following intubation, or actually I guess when he arrived with us after a couple hours of intubation. He continued to have these bloody secretions out of his ET tube, and there was some debate as to whether it represented edema or frank pulmonary hemorrhage. So a number of my pulmonary colleagues who were in the room took care of him, and glad to see everybody here so we can rehash this. His initial AA gradient was not all that high given the extent of his infiltrates and the extent of his hypoxia, and within 24 hours was down from 100 down to 15. His course was really notable for rapid weaning of his ventilator settings and was extubatable within about 24 hours. Ultimately was not extubated for an additional 24 hours for reasons that I'll get to in a second. But by 72 hours after admission was back on room air. He initially had poor perfusion, was started on pressors, that was weaned off in about 12 hours. Had a very extensive workup, again with this concern that the severity of his presentation was suggestive of a pulmonary vasculitis, either infectious triggered or collagen vascular disease triggered. So had an extensive infectious workup that was negative in all respects except for growing coronavirus from a nasal wash. His initial CRP was low, his SED rate was low. He had a weekly positive ANA, but none of the other collagen vascular studies came back positive. Again, early in his course, people were so struck by the potential pulmonary hemorrhage and the x-ray that the infectious disease and pulmonary consultants advised a lung biopsy, which was done, a thoracoscopic wedge biopsy was done on day 1. The big paragraph you see there is taken out of the PATH report. This was reviewed by our pathologists at Children's as well as sent out to the Mayo Clinic because of some uncertainties that the children's pathologists had. I think it's striking if you read through that it really fits the classic descriptions of high-altitude pulmonary edema. Yeah. Injury centered on the capillaries, secondary epithelial injury, loose filling of the alveoli, but was read as not consistent with vasculitis and only scattered neutrophils in the alveolar wall.
So not consistent with infection either?
Not consistent with infection either. Again, it took time for this to come back. This wasn't known in real time. This was the course of his x-rays over the 3 days he was with us. The day 1 film I showed you, day 2 at the time of his biopsy, and day 3 minus his ET tube. He was treated aggressively for this possible vasculitis with IVIG and steroids as well as antibiotics for possible infection while awaiting all of the studies that I've just told you were negative. I was surprised to see that no echo was done, and I'm not sure how that slipped through, but he did not have his cardiac function looked at, perhaps because he weaned so quickly off of pressors. Ultimately was discharged home on hospital day 6 with those diagnoses. Once the negative studies all came back and he was seen in follow-up, he was prescribed Diamox for future altitude exposures. But I think this raises an interesting question, is what was this? This was a child with evidence that he had pulmonary vascular disruption, he had bloody secretions, he had a lot of edema fluid, not a lot of other evidence of inflammation. So it really fits HAPE pretty well, but he presented on return to 7,000 feet from sea level, which I think is much lower than most people would consider for a presentation of reentry HAPE. So I think that raises the question as to, are there cases that are being misclassified because they are presenting at a lower altitude, or does this really not represent altitude illness per se? It's just something that looks like it in association with coronavirus. And I think the coronavirus aspect is interesting as well, since he was PCR positive but asymptomatic. And so what does that mean? Does that mean that there are a lot of patients with viral infections that our tests have not been good enough to detect until recently? Or was that something that he had weeks and weeks ago and really didn't contribute to the acute pathophysiology?
The parents told me that they live at 6,900 feet. And so to me, that was the kicker. Because can you develop reentry HAPE at 6,900 feet? I mean, people fly all the time at planes pressurized at 6,900 feet. And so that was the one problem that I had.
But how do you explain his rapid recovery? It's just,
Yeah,
it's astounding. Vasculitis,
really
infection, all of those things what you would think would have at least some subacute prolonged recovery time.
But, and again, as we mentioned with Peter's case, you see those sorts of infiltrates. I'm not used to seeing somebody like that extubated in 48 or 72 hours. That's a week to 10 days if things go well most of the time, right?
Too bad he didn't have
That speaks to the altitude component. There's clearly an altitude component. That very rapid recovery with descent and oxygenation indicates leaky lungs, probably pulmonary hypertension. There's no measurement of pulmonary artery pressure. This kid, to help sort things out, you'd want an echo. We had a kid like this who got HAPE every time he went in the mountains with his father, who was a woodcutter, and at 7,000 feet, incredibly low. And this is before the days that Doppler was emitted, or echo was readily available. Finally, we discovered he had an ASD. His ASD was closed. He never had HAPE again. So, you certainly want to rule out those kind of predisposing factors. And if he doesn't have an ASD or a PFO that opened up, or a secundum defect or something like that, or even a small VSD, then you'd certainly think more about the infection triggering leaky, let's call it leaky lung syndrome.
Sure.
acute lung injury aggravated by the altitude. But I bet he had pulmonary hypertension.
Yeah, but the ASD would predispose to pulmonary hypertension, but it wouldn't cause the pulmonary edema. So you're contemplating he's got an ASD, pulmonary hypertension from some degree of left to right revascular remodeling, which sets him up then for HAPE down the road. Okay.
Gives him a hyperreactive pulmonary circulation in response to hypoxia.
Yeah.
Did you measure pulmonary artery pressure now in the aftermath?
No, he has not been seen by the cardiologists in follow-up, at least so far as I can tell from the chart that I had access to. Although the last clinic visit was about a year after his presentation, I believe, which mentioned no further episodes, but he had not been.
And he has a normal physical performance.
Been back up to altitude with the Diamox with his family and done well.
So he'd be a great one to study with echo on ascent with and without Diamox.
Tell him he won a PA catheter.
So is there a lower limit for what you would consider HAPE in terms of elevation? There's the paper from France.
The French.
Yeah, but when you look at the French paper, those are older people.
Yes.
Did you look at their systemic blood pressures? They probably had partly left ventricular diastolic function impairment. Some of them probably had long bus or car rides, and there may be some pulmonary embolism. I think there are secondary factors quite a bit. And that's what we've done. If you have HAPE at 2,000 meters, 2,500, say, you have to look for other things like missing pulmonary artery and pulmonary embolism or whatever. So
I've seen re-entry HAPE at 7,200 feet. And it's surprising that we've had a recent series of adults with re-entry HAPE that all came back from arthroscopic surgery in Denver. And they developed HAPE on what you want to call it. They developed pulmonary edema at 7,000 to 7,600 feet on return. And I don't know if it had something to do with the surgery, the opiates, the LMA, or the tube.
Yeah, no, I have a handful of pediatric cases very similar to that.
And then this last case, I'd like to address the fact that he was very hemoconcentrated. Wasn't hypotensive, but you said he was underperfused. So was he hypotensive, or is that
so the
capillary
lowest
refill,
blood pressure that I can find in the Children's Hospital record was 80s over 40s. So on the low side for a 12-year-old, but not.
So did he get
terrible.
a fluid challenge before the pressors?
There was, yes. There was, I think, 1 20 per kilo bolus, perhaps 2.
You certainly want to give a fluid
pressors.
bolus.
Yes.
These patients can be so hemoconcentrated because they've got so much fluid in their lungs. You treat them. We did one study with arterial catheters, pressure treatment versus oxygen, and dramatic change in hemoglobin values in an hour as the fluid goes back into the vascular space. We drop the hemoglobin by 1 gram. So the second thing that maybe Peter would address, or Todd, could his pulmonary pressure have been so high, his right ventricular pressure so high that he had some LV dysfunction, and that's why he was hypoperfusing. The septum, he could have had paradoxical septal motion.
There's no description of his liver being down, of a split S2 or other secondary signs of pulmonary hypertension. But certainly, if he had severe PH, in kids we do that all the time, and then ventricular interdependence can lead to poor output from right heart failure.
Yeah, I'll just say that we never, I won't say never, so I got one upstairs that I'm contemplating this thing on right now, but this, it's severe end-stage pulmonary hypertension, on ECMO right now, trying to, bridge the transplant, but, we see lots of really high pressures when we wedge them, their wedges are fine, so while we sort of discuss this, I think it's more in the acute scenario, where you see an acute vasodilatation as opposed to the chronic, where we get RV thickening and that sort of thing, but we don't, again, we almost never see a high wedge. We couldn't treat them if they were post-capillary, for example. They're almost always pre-capillary. So I think it'd be unusual in my experience to see that kind of flash pulmonary edema, except in some rare scenarios. So maybe this is a rare scenario.
But you could have impaired diastolic filling.
Well, so diastolic filling issues, yeah. Though again, even with really, really high pressures, we don't tend to see left-sided filling pressures that are elevated in the more chronic. The acute, I know we don't frequently right heart cath, big PEs and that sort of thing to know if that.
Because I had a kid that with a child with pulmonary edema that was presented in shock, hypotensive, hypoperfused, and that was the issue. Could there have been a cardiac component because of the RV? I don't know the answer.
I mean, you almost have to hypothesize like a HOCM type scenario, like an outflow tract obstruction type scenario, which in the big even the big PEs, you can only dilate your RV generally so much in that acute before you change. So I don't. We do talk about it, but I've seen my clinical experiences. We don't see them flash pulmonary edema.
So Todd, this relationship between virus and altitude producing pulmonary vascular integrity issues is really fascinating, and you're aware of this pediatrician up in Summit County who claims that she has a few kids who get a virus and then develop what she thinks is HAPE, that she treats like HAPE as opposed to pneumonia, and they get better. Puts them on oxygen, they get better in 24 to 48 hours.
Yeah.
So, and that's not the reentry variety, it's just staying up there. Now, I don't know if you've ever seen any of those kids. Or
Well, actually, yeah, she sent me a whole series of them. I don't know, probably 10 or 12 x-rays and cases that I went over with our radiologists at Children's. There are probably, I don't know, 3 or 4 out of the 12 where there's an x-ray that's clearly compatible with pulmonary edema in the setting of some sort of minor intercurrent illness at altitude that is rapidly better with 24 hours of oxygen, documented by repeat films. And even I think in the Wiggins series from the mid-'80s, there was one case that was reported up in Leadville in association with an appendectomy that was part of his series of kids with HAPE. I've since identified a couple others. So I think this is a real thing that happens. Whether it is HAPE or just pulmonary edema at altitude, I don't know what exactly you call that. Yeah, I think it's an interesting observation she's made up there, and that's part of my series I'm collecting, is to see if we can get a better handle on what exactly those constitute. I think not all of what she's identified I buy, but some of it I do.
One last comment on that. That chest X-ray you showed, that second case is horrible. So we have in our Telluride clinic, all of our X-rays are overread by a radiology group at St. Mary's Hospital, Grand Junction. They had a new radiologist come on staff, who had never seen HAPE before. And I sent down an X-ray. It looked just like that. And he came back with a differential diagnosis that was unbelievable. He said he'd never seen a kid that sick before, and needed to be in the ICU, and needed to be tubed, and have you done a collagen vascular workup and infection? And he was so excited. And 24 hours later, I sent him the repeat X-ray. It was normal.